Good afternoon, everyone. Thank you for joining. This is the Primary Care Plus, what we're calling Phase 2 redesign, one of our partner meetings with MaineCare, our vendor who is supporting this work. We spoke to many of you last Monday, kind of refreshing on Primary Care Plus and this current state, and also where we're going with Primary Care Phase 2 or the further reforms related to primary care. This meeting is being recorded. We are going to suggest that folks put their questions in the chat as we go along, and Emily and other partners from MaineCare will periodically stop and look at those, or others of us may answer your question if it's a quick one on the fly. So I think I forgot to say that I'm Olivia Alford. I'm the Associate Director for Delivery System Reform. We can go to the next slide. We're going to spend most of the time today talking about key takeaways from primary care utilization and spending analyses that MaineCare has done for the work of this project, which will be really interesting. And you can see how it'll feed into conversations about what should a primary care payment model look like. So before we do that, I'll quickly go over some of our aims and principles. Next slide. Or next, 2 slides. So we talked briefly about these last week, but just to reorient, the goals of changing Primary Care Plus yet again is to get to a place where we really are having a primary care model that supports health outcomes, improves access to team-based primary care services that is whole person, and that actually supports practices in making meaningful practice transformation, which we believe will come in part through a change to the payment model to be a more advanced alternative payment model that gives providers more flexibility in how they deliver these services and supports that with the right financial incentives. We are hoping that through this work that we'll be able to meet some of the foundational principles here, and we left on to the right the FQHC, Federally Qualified Health Center, Rural Health Clinic principles that specifically apply to this group of providers who are critical to the primary care infrastructure in Maine. We are working separately with the FQHCs on some specific issues that come up when it comes to how federally qualified health centers are paid for primary care services, which is different than non-FQHCs. So I won't go through every single one, but we are today doing one of these, which is ensuring that we're working with stakeholders and partners in program design and implementation. So I'll hand it over to Emily to talk through the data, which is part of how we're looking at developing this model.
Great, thanks, Olivia. And as we go through, we're in the midst of our design process here. So just wanted to quickly outline what where we've been and where we're heading. Over the first couple months of this process, in March through May, we really defined those visioning principles that we just walked through and conducted this utilization and spending data analysis that we're sharing today. That analysis is meant to inform this middle bucket of processes where we're looking at options for phase 2 and thinking through what are the design elements that we want to include in the phase 2 model, which will bring us to early next year, getting closer to a designed model to share with the group. And throughout the process, of course, we'll be holding public meetings and soliciting input, and we really welcome any feedback throughout this meeting, but also afterwards as well. So we can keep going through and talk through the data. The purpose of doing this utilization and spending analysis is really to give us a good sense of the current state of primary care in Maine, to help us understand what are the challenges we're trying to tackle in a new payment model. Specifically, the analysis sought to provide insight on what are the practices providing primary care in Maine? What do they look like? How are MaineCare members accessing primary care? Are they going to many providers? Are they going to one provider? What are the utilization patterns looking like? what diagnoses are most commonly showing up in primary care settings, and what are barriers that show up in the data around access to primary care. And I'll just add, of course, we conducted this analysis in partnership with Mercer, who's also on the call, and we really did a large majority of the analysis by analyzing claims data. And so, of course, the findings are limited to what we could see in that data. Before we go to the findings, I want to talk through a few data definitions, which can be a little nitty-gritty, but I think really helps us all understand what we're looking at once we get to the numbers. We looked at claims from state fiscal years 2022 through 24, so looking backwards about 3 years. And we looked at what we call primary care services on the left here. And there are many ways to define what is a primary care service. We chose a relatively broad definition by saying any claim is a primary care service if the rendering provider on the claim has a primary care taxonomy code. And that aligns with the broader primary care spending report that MQF puts out each year. So for example, if a family medicine physician is the rendering provider on a claim, that would be counted as a primary care claim. Generally, we did not look at the code level, so we didn't look at the procedure codes. It's really based on the provider that provides the service. When we say primary care practice, so the middle box here, we're looking at service locations. So that's the MPI+3 level in the claims data with any amount of primary care services. So generally that includes any service location that has providers that have a primary care taxonomy code and provide primary care services. This is a relatively broad definition, so that will capture truly primary care practices, but it'll also capture some that provide some primary care and other services as well. We generally excluded providers with a very small proportion of spending on primary care to try to make sure that we were focusing on primary care providers as much as possible. We're also going to talk about attributed members, and I know in PCPlus attribution has its own methodology. And when we talk about attributed members here, it's really meant to be illustrative. We assigned folks with a primary care claim to a practice site, first based on which provider organization they had the most of their primary care claims, and then within that provider organization, which service location did they have the most claims. And that's not to say that that's going to be the future attribution methodology, but it is just meant to directionally show where folks are accessing care. So I realize that's a lot of data definitions before actually seeing data, but I welcome any questions. I don't see any in the chat, so I'll keep going unless anyone has anything. Okay. So I mentioned before we looked at primary care claims, and I want to be really clear about when we say claims, what payments we're including. So one more data definition before we get to the findings. So when we say claims, we're really including medical claims, but also PCPlus payments are folded in, as well as health home payments. Non-claims payments, which are listed here, including cost settlement payments are not included in the analysis, except for here where we show that they make up about 11% of primary care spending, whereas about 89% is on these claims buckets that we're looking at more carefully. So getting to the findings themselves. This slide provides a quick summary of some of the key takeaways that we'll be walking through over the next set of slides. On the left, we have our key findings, and then on the right, some of the implications that we've been thinking about in terms of phase 2 design. So first on the list, we found that existing providers who participate in PCPlus phase 1 make up a really significant proportion of the primary care landscape in the state, with FQHCs, RHCs, and tribal providers as a group also providing a really significant share of primary care in the state. And that's to say for the model, our goal will be to maintain that really strong participation that we see in phase 1 and to grow it as well. Additionally, in terms of FQHC and RHC participation, that'll continue to be an area of focus given they make up a very significant share of primary care services in the state. Our second takeaway here is around hospital-based primary care. We found that the proportion and number of primary care practices that are affiliated with hospitals is significant and has really grown in recent years in the window that we looked at. In terms of design, as we think about a value-based payment model, we know that hospital-affiliated practices oftentimes have high capacity or infrastructure to be able to participate in those models. So we think that's promising in terms of designing something that many practices will be able to participate in. Our third finding here is around access. We found that access to primary care is really similar in rural and urban areas, and we defined primary care access as the proportion of MaineCare members who had any number of primary care claims in a year. And again, that rate was relatively similar in rural and urban counties, with some of the lowest rates of access, the lowest proportion of folks with a primary care claim being in Cumberland County. As we think about phase 2 design, we're thinking about really trying to raise all boats, and that access across the state has strengths but also has challenges, and we want to design a model that promotes access statewide. Our fourth takeaway here is really thinking about the movement of patients among providers. We found that MaineCare members often go to multiple primary care practices, so they have claims at different at not just one primary care practice, but at others as well. So as we think about attribution methodologies and assigning patients to practices for this new model, we're going to have to be very careful in terms of thinking about what does it mean if how do you identify the true primary care provider for a given member. And lastly on this list, when we looked at diagnosis codes and the kinds of conditions that are being treated in the primary care setting, we of course saw many codes indicating relatively routine care, but we also saw a significant amount of behavioral health codes showing up, which really underscores the fact that behavioral health integration has been strong in the state, and that phase 2 should seek to continue to promote that kind of integration. Okay.
Emily, I just wanted to jump in.
Go ahead, Olivia.
Sorry, I didn't use the chat, but so I wanted to also acknowledge something that we talked about last week on Monday when Nat wasn't with us, but related to the second row about the hospital affiliated practices and their relatively high potential capacity for value-based payment models. We also were hearing from some of our smaller, particularly independent pediatric practices, some of which I think might be on the call today again, about how for them actually is quite a challenge around these value-based models. And so we are recognizing that as well. So I just wanted to know that we hear them on that front, and we're taking both sides of that into account when we think about the new model, but this is the data finding for today.
Thank you. All right, so the next set of slides go into a little more detail on each of these. So starting with who is delivering primary care, our analysis found statewide 1,575 primary care practices, again, based on our definition, which basically said if you have any number of primary care claims you're a primary care practice. So again, it'll include some primary care and some folks that might not be truly primary care. Of those 1,500 or so practices, about 1,000 have half or more of their Medicaid services for primary care. So that's a smaller group that is a higher concentration of primary care in the state. And we took these practices and stratified them based on a number of factors, that many of which we've talked about: hospital affiliation, FQHC versus non-FQHC, PC+ participation. And we'll go into what we found in terms of who's delivering primary care across various stratifications. So starting looking at FQHCs, RHCs, and tribal providers, this slide, each column shows 100% of the universe of primary care practices. So on the far left, you'll see out of all the primary care practices in Maine, 7.8% are FQHCs, 2.6% are RHCs, 0.3% are tribal providers. So that makes up about 11% of all the primary care practices statewide, if you're just counting practices. But if you look at measures of utilization and where people are getting primary care, these practice types make up, in this middle bar, about 25, 26% of all primary care claims in the state. And then if you look at attributed members, they make up about a third of attributed members across MaineCare. So FQHCs, RHCs, and tribal providers are really providing a disproportionate amount of primary care in the state. I'll pause if there's any questions, but I don't see any in the chat. So I will keep moving. And again, definitely feel free to jump in. So looking at hospital-based primary care practices, and this is showing the growth in hospital-based primary care practices over time. I'll say we identified these practices based on the claims having a provider type 35 as hospital-based. And on the left, you can see that hospital-based primary care has both been increasing in terms of number of practices, as well as proportion of total practices. So this darker blue line shows the number of hospital-affiliated practices, whereas the lighter blue line shows the growth in practices overall. And you see both the number and the proportion has been growing over the last 3 years. Whereas on the right-hand side, looking at how many primary care claims are at hospital-affiliated primary care sites, that number has actually stayed relatively steady year to year, around 70%, which is showing us that consolidation and practices have been more and more becoming hospital-based, but that hasn't translated to changes in utilization at this point. And to Olivia's point, of course, growing primary care in hospitals or in hospital-affiliated sites has implications for the ability of these practices to be able to join models. But of course, we're designing a model that we really want to promote across the state for hospital-based practices, but also smaller practices as well. I will continue going. Okay. So this slide is specifically looking at PCPlus participants. The universe of providers for this slide is those that have at least half of their Medicaid spend being for primary care. And on the far left, you can see that 23%, this darker blue box of practices participate in PCPlus phase 1, which might look like a relatively small percent, but when you look at the number of claims, the amount of spending, and the attributed members associated with those practices, it's a much higher proportion of the true primary care landscape being represented by these PCPlus practices, with about over 70% of members being attributed to a practice that is already participating in the program. So this is a relatively strong result in terms of PCPlus's existing kind of coverage in the state. But of course, there's still room to grow in terms of participation into this 29% up here. Okay. So that gives us a sense of what does the landscape of providers look like in Maine at this point. We also dove into who is accessing primary care and what are the patterns of utilization there. So one split we looked at was members by age. So on the left, you can see that 31% of MaineCare members are children, so 20 years or younger. Over half are adults, 21 to 64. And then 14%, a smaller proportion, are seniors, 65 plus. And then we looked within each of those groups, what does access look like? And again, access here is a member, the proportion of members who have at least one primary care claim. As you can see, children in this darker blue column have relatively high access at 75%, whereas adults and seniors have somewhat lower access compared to kids. This generally tracks with expectations. You know, kids access care with relative frequency, and we looked at, you know, is this a strength in Maine, or is this a more general trend? And looking at core set measures that CMS reports, or that states report to CMS across the country, Maine has relatively high scores for access for kids. So just to confirm that relatively strong finding. And to my point earlier about you know, PCPlus having a strong participation in the state and room to grow. Of course, 75% is a strong finding, but of course there's always room to grow as well in terms of access for kids. We separately looked at access for dual eligibles. Of course, dual eligibles make up a smaller proportion of MaineCare members, with in this darker blue pie slice, full duals making up about 14% of MaineCare members, and partial duals in the lighter blue making up 7% of MaineCare members. And for each of those, we found differential levels of access here. So among full duals, about 76% had a primary care claim, partial duals about 41%. And these numbers can also be somewhat understated, because any care that just was billed to Medicare maybe didn't show up in all of this data. But overall, for the full duals, this is a relatively strong finding. Yes, duals is Medicaid, Medicare. Thanks for the question. We also looked at access by race and ethnicity. So this graph, you can see the darker blue columns show for each group the proportion of enrollees with a primary care claim, so our usual measure of access. We also looked at ED utilization, with the lighter blue bar showing the proportion of enrollees with an ED claim. And for each group, you can also see the number of MaineCare members we're talking about at this point, with the white group being the largest. And interestingly, our second largest group is unknown. So there is a decent bit of unknown here on the far right. So that takes us to, where are enrollees accessing primary care? Once we have a sense of who's accessing primary care and what practices folks are accessing primary care at. We wanted to get a sense of geographically what the distribution looks like. We found that first, on the left, the number of MaineCare members by county is, of course, relatively concentrated in Cumberland County. Those, of course, distributed throughout the state. On the right, you can see the percent of MaineCare members in each county with at least one primary care claim. So the percent who have accessed primary care. And it's almost an inverse map where members are most concentrated in southern areas of the state. However, access rates actually appear slightly higher in northern parts of the state. When we divide up counties by urban and rural designation based on HRSA, we actually find that, as I mentioned at the top, access rates are really similar across urban and rural counties, with an average of 62% of members having a primary care claim throughout the state, and some variability from urban to rural there, which again underscores the point that the model should and will seek to lift all boats in terms of access. Okay. So how are members accessing primary care? And this gets to some of the attribution questions that we had around, are folks going to one provider? Are they going to many providers? And we found that members do oftentimes seek care at multiple provider sites and provider organizations. This map shows in each county the percent of primary care practices where more than half of their patients have received primary care somewhere else. We're only counting folks as receiving care somewhere else if they're going to a completely different provider organization, so not going to multiple sites within one provider organization. And you can see the movement is relatively high in Cumberland County at 57%, though throughout the state is really variable. And I think on average, we don't have the stat here, but it's around 50% of practices that have more than half of their patients moving around. So again, as we think about attribution, really being careful about how we define where somebody's true primary care relationship is top of mind for us.
I'll jump in. I think this was one of the findings that I think boots on the ground voices are helpful for, just to hear, it's a data finding, but does this align with what you experience as or know of within your health system or practice? I recognize some of the names on here. Is this something that surprises you, or do you see this? And again, part of it is that there's a broad definition of primary care. So sometimes primary care access elsewhere could be an urgent care facility. It could be a practice that's getting pulled in as primary care, though they offer other things, OB, for example, or other services. So does it ring true for folks?
And in the chat, we see a response that patients tend to move in, and definitely, folks, please chime in if you have other reactions as we go through too. Okay. Yeah. Just noting in the chat that rural areas have fewer alternatives, so less movement, and I think that makes a lot of sense and is reflected in this as well. Thanks, folks. So when thinking about what care is being provided, we really looked at diagnosis codes to give us a window into the types of conditions that are being treated in primary care settings. At the top of the list were codes that indicated routine and preventive care. So the first three listed here, immunizations, but then general adult and child exam codes. And of all the claims in the kind of data set, those routine and preventive codes, just those three codes made up about 11% of claims and about 8% of spending. What we thought was really interesting was right after that on the list are behavioral health codes. So codes for opioid dependence, codes for anxiety disorder and generalized anxiety disorder rose up in terms of being in this top 10 set of primary care codes in terms of utilization, making up together about 15% of claims and over 20% of spending in the state. And this gets to the point, the takeaway earlier around behavioral health and routine care really being integrated in a lot of areas of the state, and behavioral health being an offering that is core to primary care in Maine. Other conditions that rose to the top were respiratory infections, hypertension, and diabetes as well. We also looked at this separated out by provider type and found generally similar findings, where behavioral health was rising up across provider types in terms of a categories of claims. Does this generally align with folks' experience? Does this surprise anyone? Be welcome to hear. All right. So that wraps up the analysis portion. I saw the question in the chat about the slides being shared after, and yes, they'll be shared. We really welcome feedback on any of these results, especially as folks are thinking about what a phase 2 could look like. And I think people likely have this email, but just to highlight that additional feedback can go here. As I mentioned at the top, we're in the midst of thinking through the implications of these findings and assessing options for phase 2 design. And we'll come back to the group with other design questions and other options to think about as we do that design, and are looking to bring a fuller model for groups for actions in early 2026. But with that, I'll turn it to Olivia in case you have any additional wrap-up words.
Thanks so much, Emily. You did a great job walking through that data, I thought, or those data. So as a reminder, and we talked about this last week, is the model that we will present in early 2026 will be what we would call the design. How will it look? What do we think attribution will look like? What services will be in or out? How will it be paid? But it won't be the actual number, the rate that the providers would receive under that model. That will come later. So this is the time to really dream big, brainstorm, think about how primary care is best supported from a payment model perspective so that we can build into this design phase. And then once we have that foundation, we'll move into the financial rate setting portion of the project. So it will be a long project, but that is good because it's a really important topic, and we want to make sure we get it as close to right as we can. So I think we can close it out, and we appreciate your time, and you'll be please be on the lookout for additional e-messages about future events. Thanks, everyone.
Thanks, everyone.